here and let people get signed on. Okay. Good evening, folks, and welcome to tonight's Men's Health webinar with Dr. Etai Goldenberg. Tonight, we have the pleasure of hearing from an incredible person and an amazing men's health specialist in Dr. Goldenberg. He's going to start with the signs, symptoms, and treatment options of stress urinary incontinence, and then he will follow that with doing the same with erectile dysfunction. You're invited to ask questions anytime during the presentation. I ask that you find the chat feature. So if you tap your screen on your mobile device, move your mouse on your laptop or PC, you will see a toolbar that pops up. Click on the chat button, type your question in, hit submit, and we will answer those at the conclusion of the webinar. Without further delay, I'd like to introduce Dr. Etai Goldenberg. There we go.
Hi, everyone. Thank you all for logging in. Appreciate you taking the time and listening today. This will be a talk about men's health issues. I'm going to focus today talking about two things, one being erectile dysfunction and the other being stress urinary incontinence. The idea of this talk is for it to be an open dialogue. There should be the availability on here to put questions in the chat. Mike will notify us if there's questions as we go along, and I'll stop and pause for questions as we get halfway through. And we're really lucky to have our patient champion discuss his experience when I am done speaking. So my name's Etai Goldenberg. I'm one of the urologists at Urology of St. Louis. I'm the director of our men's health clinic, where we focus on treatment of men's sexual disorders, urinary incontinence, and fertility issues. I did my training at WashU here in St. Louis. Then I went to New York for a year and did fellowship really focusing on these men's health issues. And then I came back here with my family, and we've been back for the last 10 years. So I'm going to focus first talking about stress incontinence, what it is, and what the treatment options are. So overall, male stress incontinence, who has it and what it is. If you think about the urinary process, not pictured up high as the kidneys then make the urine, and the urine then fills the bladder. The bladder is a muscle, but it's very elastic, and it stretches and holds the urine until it's time to urinate. When the bladder then squeezes, this muscle contracts and pushes the urine through the urethra, which is this tube you see here that runs through the prostate, through the sphincter muscle, and then out through the penis. When you don't want to urinate, what stops the urine from just leaking out is muscles. There's the sphincter muscle that's here, and inside the prostate is another sphincter muscle that protects from leakage when you stand up, when you cough, when you have exercise. That muscular unit stops leakage from occurring. So what are the types of incontinence that are out there? So that we're going to focus on today is stress incontinence. When that muscle unit that sits over the urethra and protects from leakage, it doesn't function as well as it used to. That is leakage from coughing, sneezing, activities. Those activities cause a stress or a pressure, and that pushes the urine out. There's something called urge incontinence. So urge incontinence is when the bladder is overactive. Some people would call this an overactive bladder. That's when you have this feeling that you have to go and you have to go right away, and the urine then leaks out. And some men have a combination of both of these, which we call mixed incontinence. So focusing on stress incontinence, the most common reason where a man will have stress incontinence is because of some type of procedure that's going to injure that sphincter muscle, which is usually prostate cancer treatment. In women, they often have stress incontinence because of childbirth, but in men, the most common reason is because of prostate cancer. When a man has their prostate removed surgically, it's about 10% of guys have significant leakage a year after their surgery. Now, it's really common for men to have leakage right away after surgery, but that usually improves with time, but persistent leakage sits around 10%. Other things that can cause stress incontinence in a man is either neurologic disorders, treatments for prostate surgery, most commonly a TURP procedure where the prostate is removed for non-cancerous reasons, radiation therapy, or pelvic trauma. So when a man has prostate cancer, what occurs is the options for treatment is a radical prostatectomy, which is the most common surgery and also the most common reason for the stress incontinence. Most commonly, these surgeries are now done robotically, where the nerves that run over the prostate are pulled over in a nerve-sparing approach, and an incision is made here on the top of the prostate where it's connected to the bladder, and on the bottom of the prostate where it's connected to the urethra. That sphincter mechanism is right beyond this area, the external sphincter. Once the prostate is removed, there's the opening of the urethra and the opening of the bladder, and these are sutured back together. At this point, you're relying on less muscle, only the muscle that was beyond where the prostate is to protect from leakage. So what are the options? And definitely in the short term, after someone has their prostate removed, the most common thing to do is to work on strengthening the pelvic floor or strengthening those muscles. That's done with Kegel exercises where you focus on strengthening those muscles. Some men will see a pelvic floor physical therapist to help strengthen those muscles, or have biofeedback where the therapist works with you on strengthening those muscles with some feedback electrodes. Pads, diapers, catheters, clamps are all ways to stop leakage. Also a way for us to monitor and think how much you're leaking. I really use the number of pads a man wears per day after their surgery to really quantify how much they're leaking as we plan what procedures or things we can do down the road. Part of leakage is really the cost, and I see lots of guys that come in and say, I leak this number of pads per day. Number one is its impact on your quality of life, but there's also a cost to this procedure, to this amount of leakage. And I always remember to focus on this and think about it when we're talking to a man about their incontinence. If a man has leakage a year after their prostate procedure, either their prostate's removed for cancer with a radical prostatectomy or from a TURP or a resection of their prostate, and you've really tried the other things. You've tried muscle strengthening with Kegel exercises. You've tried working with a physical therapist, and you still have bothersome leakage. I usually recommend thinking or considering the options of some type of surgery. The two most common surgeries that we will do for a man with stress incontinence is one is a male sling. A sling uses a piece of mesh that goes under the urethra and gives support to the muscle that you still have left behind. The thought being that muscle just isn't strong enough to really stop the leakage, and putting that piece of mesh behind the urethra allows for extra support. I usually tell my patients, think about it like doing a pull-up, but if you can't do a pull-up, someone holding your legs allowing you to do the pull-up. If you don't have any muscle left behind, you really still can't do that pull-up. But the idea is the sling really allows extra support for the muscle that you have, just really helping it out. I tend to recommend a male sling for someone who leaks 3 to 4 pads or less per day. Someone with severe incontinence or someone who's had a sling and hasn't helped them enough is someone that I usually think is a good candidate for what's called an artificial urinary sphincter. This is a cuff that goes around the urethra that you squeeze a small pump sitting in the scrotum to control your urination. So in a little bit more detail here, this is a picture of what a sling would look like. So if you see here, this focused right here is where the prostate used to be. This is that muscle unit that's there. What happens is we put this piece of mesh and attach it to the bottom side of the urethra, and then that mesh is then looped through the obturator canal, which is through the hip bone or next to the hip bones, and then tensioned or pulled up. And as it's pulled up, it sits like this under that muscle area, giving extra bulk or support. So that way, when you cough or sneeze or have heavy lifting, there's more support for that muscle and to prevent leakage. This is an outpatient procedure where you can keep a catheter overnight. So some of my patients go home the same day. Some elect to stay overnight and have a catheter removed the next day. Satisfaction rate is very high. 90 to 94% of patients would be happy with this procedure. Like I said, it's minimally invasive, a small incision under the scrotal area, and then 2 small incisions on the leg to pass the mesh. There's no interaction with the device and should work immediately. However, I do recommend that my patients take it very easy after a sling is placed. So it's about 6 weeks of light activity without any heavy lifting, sports, sexual activity, really anything that bends your pelvic area. For men with heavier leakage or not only of their prostate removed, but prostate removal and radiation that causes a severe leakage, or a man that's had a sling and is in that percentage of men that still has persistent leakage after a sling, we would discuss placing an artificial urinary sphincter. This is a cuff that goes here where the sphincter mechanism used to be, or a little bit farther down on the urethra, and encircles the entire urethra. That cuff is placed. It's filled with saline or salt water, and it's connected to this control pump that sits in the scrotal skin. When you want to urinate with an artificial urinary sphincter, what you do is you squeeze this control pump. What it does is it opens the cuff and lets the urine flow. So that in all other times that cuff is closed and keeps the urine from leaking until you choose to allow the cuff to open and let your urine flow through. This is a quick video showing the mechanism of how this artificial urinary sphincter works. I think sometimes pictures 1,000 words, and a video is, I don't know how many more than that. But if you look here, here is this control pump. When you squeeze that pump right there, what happens is the cuff opens, allows the urine to flow through. It stays open, usually for about 1 minute to 2 minutes, and then on its own, slowly closes down, and therefore prevents leakage of urine until you squeeze the pump again. The artificial sphincter has been around for like 30 to 40 years. It's really the gold standard for men with urinary incontinence, with 90% satisfaction rate, 92% of men saying they would have it placed again or recommend for a friend. This offers men that have a weakened sphincter of all levels achieve continence. It mimics the way the healthy sphincter was supposed to work. It's completely inside the body and has a very high satisfaction rate. Both these surgeries, I must say, are implanted devices inside the body. So anytime you have a device that's implanted, the thing we always fear is infection. We do give antibiotics before, during, and after the surgeries in order to reduce that risk of infection, but does not make that risk zero. Anytime we put a device in that can affect continence, it's possible that we either don't give enough restoration of continence where you may still have some leakage, or that we put too much in that you have urinary retention or the inability to urinate. Most insurance companies would cover placement of a sling or an artificial sphincter, but before we would do it, we would, number one, do a full workup where we assess what causes your leakage and your degree of leakage, often with a cystoscopy where we look inside to see how much muscle is left behind. And then we present that to your insurance company. And for the most part, these are covered procedures. I went through this pretty quickly. Definitely, if this is something that is an issue, I think it's really important to talk to your urologist or your primary care doctor about your level of leakage. Really keep an idea of how much you leak in terms of counting the number of pads that you wear in a day. That really helps me or other urologists really quantify how much leakage you have. And then fixyourincontinence.com is a really nice option for patients to go online and look some more detail about these options. Like I said, a urologist and most men that have had surgery for prostate cancer or a TURP procedure for enlarged prostate usually have a urologist, so it makes sense to start talking to them, the person that you're already seeing. But someone like me that's a prosthetic urologist, someone that really focuses and most of their practice is treatment of men with prosthetic or implanted devices is the next step. If you're interested in speaking to me about this, at the end of the talk, you'll get information on how to make an appointment. So that kind of summarizes stress incontinence. Mike, did you have questions you want me to answer next and before I move on?
We didn't have any questions come in yet. We can hold off till the end to get to those.
Okay. So, sorry, that was supposed to be my quick break.
I messed that up for you.
It's okay. Still love you. Okay, so if there's no questions, then I'm going to move on to talking about erectile dysfunction and what the treatment options are for erectile dysfunction. So what is it and who has it and what are the most common causes of ED? So ED, erectile dysfunction, is the persistent inability of a man to achieve or maintain an erection firm enough to have sexual intercourse. It's really common. And so I always present these numbers. I do this, usually once or twice a month. I'll give presentations like this. And, 1 in 5 Americans over the age of 20, always just still is, such a high number. And it really, if you look around the room and know that 1 in 5 over the age of 20 and more than half of men over the age of 40, really, I think, reminds me about how common of an issue this is for men in the United States. Approximately 40 million American men. So when I think about erectile dysfunction, I think in simple terms, the flaccid state, the penis looks like this. There's these 2 red areas in here. These are the corporal bodies. These are cylinders that have blood vessels in them that fill with blood when you want an erection and let the blood come out. Underneath is the urethra, shown here in blue. That's where you urinate through. When a man wants to get an erection, the blood vessels, the artery inside the penis, inside the corporal body, opens up, delivers the blood inside, and the veins inside block off the blood from leaking, allowing that erection to stay firm. What are the most common causes of a man to have erectile dysfunction? So as I described, this is a phenomenon where blood flows into the penis. So any type of vascular disease is really the most common reason why a man will have erectile dysfunction. Additionally, diabetes, which can affect nerve endings as well as affects blood vessels, is another very common cause. Medications, especially medicines that affect blood pressure or the way blood flows, are another very common issue. And things that we talked about before, like prostate cancer or pelvic trauma, are also some of the top reasons for erectile dysfunction. So I want to talk a little bit about each one of these most very common disease processes and why they affect erectile dysfunction. Starting with diabetes, the data would say that 15 million men in the United States have diabetes. And in men with diabetes, erectile dysfunction occurs a lot earlier, approximately 10 to 15 years earlier. And men that have diabetes and try the most common the most common treatments for erectile dysfunction, like pills, really don't respond as well, because usually diabetes not only affects the blood flow, but also affects the nerve endings. Things that can influence the degree of erectile dysfunction due to diabetes is age and also the number of years a man has diabetes, how well their blood sugars are controlled, the presence of any other microvascular complications or neurologic complications from their diabetes, medications that they take for blood pressure or diuretics, as well as if you have diabetes and heart disease, you have multiple risk factors for erectile dysfunction. Speaking of heart disease, when I focus on erectile dysfunction, we're talking about this penile artery, this cavernosal artery that delivers blood into the penis. This blood vessel is about 1 to 2 millimeters in size. If I compare that to the common blood vessel that affects heart disease, the coronary artery, that's about 3 to 4 millimeters in size, so much larger. So any man that comes in and says, I have a history of a heart attack, or I have heart disease, or I have, a CABG or replacement of those blood vessels, and had narrowing of these blood vessels, almost for sure has some narrowing of the blood vessels that are in the penis. In addition, same idea with the man that has a history of stroke because of narrowing of their carotid artery or narrowing of the femoral artery that goes in the leg. A man with heart disease, how do they reduce their risk factors? So anything that's healthy for your heart and healthy for blood flow is also healthy for a man with erectile dysfunction, especially erectile dysfunction due to heart disease, including exercise, physical activity, reducing your stress, losing weight, and not smoking. Low testosterone. So testosterone is the hormone that's produced from the testicles. The testicles have 2 jobs. They make testosterone and make sperm. Testosterone is made from the testicles and gets into the bloodstream and allows a man to have sex drive, desire. It also allows medication for erectile dysfunction to work better. As men age, their testicles don't do as good of a job of making testosterone, with about 4 out of every 10 men over the age of 45 having a low testosterone. And low testosterone is associated with a lot of the other risk factors for erectile dysfunction that we talked about, including being overweight, having diabetes, having high cholesterol. And so when a man has low testosterone, they often have fatigue, decreased muscle strength, increased body fat, sometimes feeling less motivated, having less sex drive or libido, or having erectile dysfunction. So when a man comes in and says that they have complaints of erectile dysfunction, and especially if that man says, I have decreased sex drive or decreased desire, we usually check a testosterone. Testosterone is considered low if you check it twice in the morning. So we usually recommend having your blood test for the testosterone before 10 a.m. if possible. If you have 2 blood tests that show low testosterone, you're usually a candidate for treatment with testosterone, which includes either gels or a patch that's placed daily, injections, which are weekly, oral medication, which are newly FDA approved. Those are usually twice a day options, or pellets that are placed on the skin every 3 to 6 months. Prostate cancer, this diagram will look familiar. This is what we talked about before. When a man has prostate cancer and their prostate's removed, these nerves that run here, this neurovascular bundle is pulled aside. That neurovascular bundle is what really tells the blood vessels in the penis to open up to allow blood to flow in. So after the prostate is removed, those nerves are injured to some degree by just being pulled off the prostate, and sometimes do have permanent damage. And the literature would say about half of men that have some intervention for prostate cancer have it being either surgery to remove the prostate or radiation therapy. They'll have a decrease of their erectile function after that treatment. Peyronie's disease. So Peyronie's disease is a plaque formation in the penis. This is usually a small incidental trauma that causes an injury. And what happens is your body overcompensates and forms scar tissue as it heals from that injury. The most common is an upward curvature, but curvature can be in any direction. And what happens is this plaque forms on the outer part of the corpus cavernosum of the corporal body. What happens is then you get an erection, and when you get an erection, that plaque doesn't stretch as much as the rest of the penis, and so you have curvature in the direction of that plaque. This can often be associated with erectile dysfunction, and those together can cause difficulty with sexual activity. If you have penile curvature, you don't always have erectile dysfunction. If you have erectile dysfunction, you don't always have curvature, but they do go hand in hand. If a man has penile curvature because of this Peyronie's disease, usually the next step is evaluation. Usually I'll do an ultrasound test of the penis and assess how much that plaque is calcified and look at the size of it. And based on that, we can discuss options for treatment, which include Xiaflex. Xiaflex is a medication called a collagenase that's injected into the plaque to break down the collagen in it so it stretches or is elongated. In addition, other options include surgery for Peyronie's disease, which includes a plication procedure, which is a straightening surgery, a incision or excision, and then a graft, which is where the plaque is removed and then a replacement graft is placed in. Or a penile implant. A penile implant is definitely an option for a man that has Peyronie's disease together with erectile dysfunction. Okay, so I'm going to talk next about treatment options. Mike, do you have any questions first, or should I move on to that?
I think we'll keep going. We can do questions at the end. Again,
Okay.
Folks, use the chat button or feature to submit your questions anytime.
All right, and I will forge ahead. Okay. So what are the treatment options for erectile dysfunction? We put this slide in because I think more and more it's really common for primary care physicians to really talk about erectile dysfunction. There's been a lot more disease state awareness where primary care doctors feel more comfortable, at least starting the workup and starting talking to men about their erectile dysfunction, especially checking testosterone levels or starting pills for erections. With that said, erectile dysfunction is so common that even though those options will treat some men, many men don't have enough of improvement with either testosterone checking or testosterone medication or oral therapies. And so those are patients that should come to your urologist or especially a prosthetic urologist like me that can really discuss all the options and what the pros and cons are of each of them. And those options include oral therapy or pills, wave therapy, injection therapy, suppositories, vacuum erection devices, or penile implants. And I'm going to talk in more detail about each one of these. So oral therapy has been available and on the market for approximately 40 years now. The way it works, the most common therapies are Viagra or Cialis. There's some other ones on the market as well. These medications allow the blood vessels in the penis to become more sensitive. And so when they're taken, you do not get an erection. However, they allow, with stimulation, for more blood to flow in with the same degree of stimulation. Viagra and Levitra are usually taken about an hour before sexual activity and stay in the system for about 4 to 6 hours. These can be affected by food and are taken more effective when taken on an empty stomach. Other medicines like Cialis last in the body for about 36 hours, and they do have either an as needed or a daily formula. Oral therapy is effective for about 60 to 80% of patients, and so for that reason, it really is the first line therapy for most men with erectile dysfunction. That said, there is failure with time from this medication. In addition, men with diabetes, men with prostate cancer tend not to respond as well to pills, mostly because they have a neurologic component as well as a blood flow issue. Side effects with pills often are flushing or headaches or a stuffy nose. Cialis can cause a low back pain. There's certain medicines you can't take together with these, notably nitrates for chest pain. In addition, alpha blockers, which are medicines to help with urination, should be separated when they're taken. Low intensity shockwave therapy is really become something that we talk about a lot more often. This is an off-label or a non-FDA option for erectile dysfunction. The way this works is these small pulse waves are sent to the penis with a device that's pictured here. All areas of the penis are exposed to these waves. And then what happens is you have these 6 therapies, and the thought is that it causes neovascularization and repair of some of the damaged blood vessels in the penis. Like I said, this is an off-label therapy, and so because it's not FDA approved, it's usually not covered by insurance and it's cash pay depending on where you get it, at different prices set by those facilities that offer it. I tend to recommend shockwave therapy really only to men with only blood flow issues. So if you have diabetes as the cause of erectile dysfunction or because your prostate was removed, I usually don't recommend wave therapy because this therapy helps blood vessels. It doesn't repair nerves. It's really best, I think, for guys with mild to moderate erectile dysfunction because it really only gives a mild to moderate improvement. But if you have mild to moderate ED, or if you're taking the pills and get a nice response to them and don't like taking the pills or have side effects from the pills, I think wave therapy is a reasonable option. A vacuum erection device. This is a cylinder that goes over the penis and then pulls blood inside. It's pictured here on top. The cylinder goes on top of the penis. It forms a vacuum for negative pressure space. And the blood is then promoted to pull in. And then you place this band on the base of the penis. The band maintains the erection and keeps the erection firm. You keep the band in place until you're done with sexual activity. This vacuum device does work for nearly all patients because you're mechanically pulling the blood inside. That satisfaction rate really does vary, somewhere between 60 to 80%. And then there's a fair number of men that will try vacuum therapy for a while and then stop using it. The ring can block ejaculation. It can change sensation of the penis and does have a lack of spontaneity associated with it. Urethral suppository is probably one of the least common options that we'll use because it is uncomfortable to place this device or apparatus into the penis and actually is relatively expensive. But the way it works is a small pellet is deposited into the urethra, into the urinary tube, and then it's left in place and it dissolves and then it's absorbed by the penis. This allows the blood vessels to be exposed to that medicine and then promotes an erection to occur. Occurs nicely about 40 to 60% of men. Side effects, it can cause lightheadedness and dizziness because it's placed. Sometimes it affects the blood vessels in the pelvic area, so you get pooling of blood into that area and then get lightheaded or dizzy, and there can be some difficulty with urination or some blood in your urine after it's placed. Instead of the suppository, much more commonly, we will teach men to give themselves an injection to the penis. It's the same type of medicine, but it's directed specifically where you want to go, into these corporal bodies. These two corporal bodies, or the two circles above that fill with blood when you get an erection, actually communicate with each other. So you do the injection to one side and it does affect both of those corporal bodies. The medication goes in and allows for an erection within 5 to 10 minutes. And for the most part does give a strong erection if you have sufficient blood flow. The side effects of these injections is painful to some degree. It is a tiny needle, but some people do get discomfort from the injection. There is a risk of fibrosis or scar tissue forming. In addition, the medicine is very potent, and if you get too much of the medicine, you can have a prolonged erection or a priapism. And the other option is a penile implant. A penile implant is a surgical procedure, and what we do is we replace those blood vessels inside those two corporal bodies with cylinders. Those cylinders are then controlled by a pump that sits inside the scrotum and then shifts fluid from a reservoir that sits up in the belly. This is a really excellent option for men that have either failed or are dissatisfied with the other options that we discussed beforehand. This is a surgical procedure, so there is risk associated, including a small risk of infection, a risk of bleeding, or dissatisfaction with the device. 98% of men tend to be happy with it, with a satisfaction at 7 years of still 94%. There's different types of implants. Like I said, the corporal bodies are replaced by cylinders, and that's really what makes all the implants the same. The difference is how they function, with a concealable or a spectral device being a firm rod that you can bend up and bend down as you like, a ambicore or two-piece device, which is controlled by a pump that sits in the scrotum without a reservoir, or the most common device that's placed, which is a three-piece device, which are cylinders that go in the penis, a pump that sits in the scrotum, and then a reservoir up in the pelvic area. You see that this device is yellow. The reason that one is yellow, the three-piece device, which is the most common device, comes coated with antibiotics, and this does significantly reduce the risk of an infection with a three-piece device. So in this video, in a moment, you should see how the implant works. Here you go. So in this cartoon, you can see that in the erectile bodies, the two cylinders are in place. They rest in the back against the pubic bones. You squeeze the pump, and then the fluid shifts from the reservoir into the cylinders. You can then keep the cylinders inflated for as long as you'd like, and then you press the release button. And once the button is pressed, the cylinders then empty, and sometimes you squeeze the sides of the penis to allow all the fluid to come out. All right, and this is a video of a patient of my friend Dr. Cartman's patient. And you'll see here in a moment. So this man has an implant in place. You can see there's nothing external. Everything is hidden inside the body. The patient's bringing the pump up to the skin. And you can see with his right hand that he's squeezing the pump. What's going on is he's shifting the fluid from the reservoir into the cylinders. When the device is completely inflated, you can see it looks like a very natural erection. You can leave the erection for as long as you'd like. And then when you like the erection to go down, you can bring that pump up to the skin, and you can see the pump is here on the bottom, and the release button is right there under his finger. You then squeeze that release button. You see the fluid then does come out of the cylinders, and in order to really get the device fully deflated, you squeeze the sides of the penis, and what it does is it shifts the fluid out of the cylinders and really promotes them to go back up to the reservoir. So you have a concealed and device that's really not noticeable and really deflated at that point. 97% of men are happy they have the implant, and well over 90% would recommend it to a friend. As I mentioned before, any device that's implanted inside the body does have risk. The biggest thing we worry about and the feared complication of any implant surgery, any device that's implanted inside the body is an infection. The risk of infection is somewhere about 1 to 2% with the device. Reducing the risk of infection by having you take antibiotics beforehand. I have my patients do a skin wash beforehand to reduce the amount of bacteria they have on their skin. Taking antibiotics through an IV during the operation, and then taking pills afterwards to reduce infection. Men with diabetes and spinal cord injury do have a higher risk of infection. Revision or repeat operations do have a higher risk of infection as well. It's usually an overnight stay or an outpatient procedure to have a penile implant placed. Most of my patients have a catheter overnight that's taken out the next day. I have a majority of my men will go home the same day and then just take their catheter out at home. You do need to take it easy about 2 to 3 weeks after the surgery, and it's 6 weeks until you can engage in sexual activity after you've been cleared by your doctor. The upside of a penile implant is that it's designed to be permanent and spontaneous and hidden inside the body. It should have no negative effect on ejaculation or orgasm. It's been out for over 40 years, and over 500,000 men have had a penile implant placed as tried and true option. Insurance often does cover a penile implant, but no guarantee. So before that we would do a surgery like this, we would verify that your insurance would cover a penile implant surgery. Maybe to take a step back away from a penile implant, just overall, erectile dysfunction is really common. More than half men over the age of 40 do have ED. And so it's really important to figure out what the option is best for you and for your partner. There's not one answer that fits all. I really think that it's important to talk to your partner, talk to your doctor, really weigh the pros and the cons of all the options and decide what is the best next step for you. And it's a little bit of trial and error, figuring out what the right option is and what works best for you. edcure.org has much more information if you guys are interested. I was going to open up for questions now, Mike, or do you want me to have Cliff talk?
I think waiting till Cliff talks and having questions available.
Questions at the end. Yep. Perfect. I love it. So we're really lucky to have Cliff here to talk about his experience. I'm going to turn the mic over to him, and then I'll be here for questions at the end.
Well, good evening, everyone. What you're going to hear basically is the journey that I took with my wife from the time I was diagnosed with prostate cancer through the terrible times of ED and then curing the ED. When I was 58, I had a positive prostate cancer result from a test. And being the kind of person I am, I decided to have the prostate removed. After the prostate was removed, I did have some incontinence for a while. And I also ended up with ED. I started with my regular doctor, my private doctor, and he said, we'll put you on Viagra and the pills will be fine. Well, the pills were fine, except they didn't work. And I got terrible, terrible headaches from the pills. Headaches to the point where I'd have to lay down and I couldn't pick my head up off the pillow. Now, a lot of other people have had great results with the pills. I did not. So I went back to him and decided, okay, pills don't work. What's next? And he said, well, we got this vacuum device, this external device that fits over your penis. And it really gives you good results. It'll give you a solid, rigid erection. And there's no problems with it. Bought one. And I will tell you, you want to buy one with a prescription from a doctor that you buy from a surgical house that sells surgical equipment. You don't want to go to a sex store and buy a $25 one. You want to buy a good one. It did work. A couple of things that we found with it were, number one, when you use it, your penis becomes a little blue because it's cold. Secondly, spontaneity is out the door. It seems that the more excited you are as a man, the longer it takes to pump this thing up and get the band on. It does work. It does not, unfortunately, look natural to your partner because it's blue and it's really pumped up and you have a big swollen blue penis. But it does work. But after about 3 months, I gave it up because I found that taking the band off of the penis was just very, very hurtful. It would go up the shaft fine, but going over the head of the penis, it really was painful. And at that point, I went into a really big depression because I did not know what else was out there. And my regular doctor didn't give me any idea about who to go see or anything else. So for about a year and a half, almost 2 years, and no sex, no erections, nothing. And got to the point where, you totally lose your manhood. Luckily, I did get a response and a letter from a prosthetic urologist who said he was having a meeting like this, but it was way back, way before COVID. And I went to this meeting with my wife, and he talked about the other options that were available, the little pellets that you put in with Muse, the injections, and the implant. Well, I wasn't too thrilled with the pellets. I was less thrilled, basically, for myself with the injections. So we talked to the doctor about the implant and found out I was a candidate for it. And the day after my 60th birthday, I had the implant done. I will tell you, it's the second best thing I ever did in my life. The first one was marrying my wife 54 years ago, but this was the second best thing ever. I was in the hospital overnight, went home the next day. I really did not have a lot of pain. I had a lot of discomfort, but I found that taking Advils really took the edge off of everything. I basically went back to work after 2 weeks. At the 4th week, I went back to the doctor's office. They showed me how to use the unit. I used it for 2 weeks, and at the beginning of the 6th week, started to have intercourse again and felt like I was 18 years old. Everything was phenomenal. I've had the implant in for 14 years. It worked fine. Finally, it did give out, and I did have it replaced. And when I was 74, so 2 years ago, I had it replaced. And I will say it was, again, a good decision. People ask me about the implant and about what you can and can't do. I will tell you a few things they say. Number one, at the end of 6 weeks, I went back to working out at the gym with my friends. I would shower with them, and they had absolutely no idea there was anything inside me. It's totally hidden. The second thing people ask me is, well, what happens when you go through the airport and through the metal detectors? The answer is absolutely nothing. I do have artificial knees, so my knees do set off the alarms, and they take you to the side. And I don't know if you ever had this, but they take this wand and they go up and down your body and inside the inner thigh and around the crotch and everything, and nothing happens whatsoever. It's totally innocuous. The other thing is, people ask me, does it stop you from having any type of X-ray scans, MRIs, CTs, anything like that? The answer is no. And finally, they ask me, well, does it have any interference with urination or anything with your bladder? And the answer there is absolutely not. It has no interference at all with urination, with anything with your bladder. If you do have anything with your bladder, a cystoscopy worked great, and it doesn't, the implant has no effect whatsoever. It will not hold you back from anything. Like I said, I've now had the implant for 16 years. I'm 76 years old. Hopefully this one will be my last one, but you never know. And I will tell you, it has given me back from the very first time I used it. It has given me back my manhood. For almost 2 years, when you can't have intercourse and you just don't feel like a full man, It's very, very taxing on your body and on your soul. And a couple of times it got pretty close to saying, it's not worth being here anymore. But the implant did work. And I would suggest that if anybody is interested, I can tell you, ED is not just a male issue, it's a couples issue. If you have a partner, my suggestion would be to take your partner to the doctor's office with you so they get a better understanding of exactly what's happening with you. And it's just a couples issue and they buy into it a lot better. And I can tell you that my wife has said many times, if she didn't know I had the implant, she couldn't tell. So if you're single and dating, nobody has to know you have it, and they really can't tell you have it. So at this point, I'll turn it back, Mike, to you and Dr. Goldenberg for any questions anybody might have.
Thank you, Cliff. So we had a pre-submitted question here. This individual had gone to a local men's health clinic and used pills that didn't work and was worried about the cost of injection therapy there and also the wave therapy there. They wanted to know, are there lower cost options for these medications, and does insurance cover any of the ED treatment options?
Yeah, so many insurance companies do cover erectile dysfunction treatments. It's interesting that there's definitely lots of variability on what is and what isn't covered. At Urology of St. Louis, we've really tried hard to make it as affordable as possible for patients to get all the options. If your insurance doesn't cover your medication, we do have an in-house pharmacy that we will dispense the generic form of Viagra, the generic form of Cialis, and so if your insurance doesn't cover it, or if it's cheaper even just to get it at our office, or if it's more discreet that you'd rather just purchase at our office, they're pretty low prices for those medications through us. In terms of wave therapy isn't covered by any insurance because it's an off-label option. That said, my understanding is comparatively, if you do wave therapy at our office, it's significantly cheaper than it would be at other facilities that you hear advertised on the radio. And then in terms of penile implants or maybe injection therapy, I tried to find, my understanding is our costs here are really inexpensive. I use a pharmacy that's actually, usually the pharmacy I use, there's one in Florida, there's one in California that will ship the medicine to patients. I try to find the cheapest place that's also safe and FDA cleared to ship Trimix and other injectables. But my understanding is from patients, it's about 1/10 of the price as some of these men's health clinics that you hear on the radio. And then finally, penile implant surgery is covered by most insurance, even insurance that doesn't cover pills or injection oftentimes will cover a penile implant. And so before we do a penile implant, we verify insurance to make sure it's covered. Like I said, for the most part, it is covered. There are some insurance companies that have it as a plan exclusion, meaning that it's not covered. And then for that reason, we try to give the cheapest option for doing the penile implant as a cash pay option. It still is rather expensive if your insurance doesn't cover it, but we try to do our best to reduce the cost as much as possible by doing it as an outpatient procedure, so you go home the same day, using facilities that have decreased fees. Does that answer the question?
Yeah, definitely. Thank you for covering that. And just for clarification, before somebody would have an implant surgery, and if they would know, or your office will figure out if it's covered, and then they could understand the cash price too.
100%. And so what happens is, if let's say you came to see me in the office and said, I'm interested in a penile implant, or I had a penile implant that malfunctioned, I needed replaced. And the next step is that I would send your information to a third party, often assisted by Boston Scientific, to help us verify the insurance. And then within a couple weeks, or usually I think it's about 10 to 14 days after we submit that, you'll get a response to say, yes, it's covered, or it's covered 80% or 20%, and you should know exactly what all your out-of-pocket expenses would be for the procedure.
So there's a question about injections and, excuse me, how long, sorry, I had a frog in my throat, how long that lasts, and then after climax, should the erection go away?
So when for penile injections, usually it's about 5 to 10 minutes until the medication has affected, but everyone's a little different. Stimulation will obviously speed it up and help that erection get a little firmer faster. The medicine is variable depending on, some men have more or less effect from the injection, but the average is the erection should last about 20 to 40 minutes. And with ejaculation, you should have some decrease in the firmness, but I do have a lot of patients that tell me they do maintain their erection after the injection. A lot of it's variable based on the amount of medication that was injected and your blood flow and how you're affected by the medication.
So we have a few questions about the specific cost of the implant, but again, I think that's going to be on an individual basis.
It's really variable, and I will say, if you have Medicare and a secondary, most of my patients pay, I think, zero or next to zero. It's patients with commercial coverage, so men under the age of 65 or that aren't on Medicare do have the ones we really do verify, and I've seen huge variability on coverage and not coverage. And so if you do, my understanding is if you look to see if an implant is a plan exclusion is really the most important thing to look for. Some insurance companies just don't cover a penile implant, but that is a small minority. Most men do have coverage, especially if we can explain that you've tried the other options, or at least we've discussed options of pills and injections and vacuum devices.
Now, I do see that it looks like for some people the chat is not working. So in that case, just use the box that says Q&A and enter your question there. So next questions, I think for both of you. Does the implant allow ejaculation? And is sex impacted in any other way, such as sensation with the implant?
It should not be the way the implant is placed, or at least the way I place the implant. It's very far away from the neurovascular bundle, so the odds of change in sensation are very, very low, and ejaculation should be maintained as long as you're able to ejaculate beforehand. So men that had their prostate removed as their cause of erectile dysfunction won't have an ejaculate. That's because their prostate was out, so that's not restored with an implant. But that said, if you were able to ejaculate beforehand, there should be no negative implant from placing an implant. Cliff, do you have anything to add?
I would just say that I found that there was no difference in feeling of the orgasm with the implant. It was the same as without the implant, before I had ED. Nothing really changed. It was good.
Thank you both. Now there's a question about side effects of low testosterone medication. Are there side effects, and could this potentially impact erectile function as well?
Yeah, so testosterone is a hormone that's produced from the testicles that helps with energy, sex drive, libido, desire, concentration for some men. And if your testosterone's low, the hope is if we give you testosterone that those things will improve. Number one, no guarantee that if you say I'm tired or run down or have a low sex drive, if we raise your testosterone, not all men have improvement of those symptoms. There's lots of other things that can cause a man to feel that way, be it depression, thyroid issues, or other medical illnesses that can cause those feelings. But if your testosterone is low, it's usually a reasonable thing to try, and usually we try it for 2 to 3 months to see what your response would be. Side effects of the testosterone. So anytime we put someone on testosterone, there's a chance that it can raise their blood pressure a little bit. In addition, it can often thicken the blood or increasing the amount of red blood cells, causing something called polycythemia. Both those things can increase the risk of a potential heart attack, stroke, or blood clot formation. And so we do monitor a man's red blood count closely, and I recommend that they follow with their primary care doctor to do everything they can to reduce their risk of a cardiovascular event. In addition, testosterone therapy can increase the size of the prostate. It can worsen urinary issues. It does not cause prostate cancer, but if you had prostate cancer and you're on testosterone, there's a potential that it may make it grow faster. Those are the big ones.
Okay.
Also, it does cause fertility problems.
Now, there's a question about beta blockers. Could those potentially impact erectile function?
Yes. Beta
And then-
blockers are a really common blood pressure medicine. They'll lower your blood pressure, but therefore, by lowering your blood pressure, decrease the amount of pressure in the blood that goes into the penis. And so beta blockers are a really common reason for erectile dysfunction. Now, that said, don't stop your beta blocker if you hear me say that, because there's a reason your doctor put you on it. So make sure you consult with your cardiologist or primary care doctor before you stop or change medicine. But it is possible that maybe a different blood pressure medicine will work better for you and cause less fatigue.
Now, why would somebody not be able to ejaculate? Is that related? Is prostate cancer treatment the only reason?
No, there's other reasons why a man can have difficulty with ejaculation. Sometimes it's nerve endings that are affected. Lots of antidepressant medications can affect ejaculation. So any medicine that affects nerves or nerve endings or the way nerves feel can cause changes in ejaculation or delay in ejaculation. Diabetes can affect nerves. Diabetes often causes something called retrograde ejaculation. So that way, even though you have a climax, no fluid comes out because of the way the nerves are affected by diabetes. So lots of reasons, some fixable and some not.
I go to the last question here. Pre-submitted, wondering about pain associated with an implant, if that's something that persists after that initial 6 weeks.
So most guys, we do the surgery. They usually have significant pain for maybe 1 to 2 weeks. Everybody's different. I have some guys that, I write narcotic pain medicine for all my patients after surgery. Some guys take it and some guys never take it and just take Tylenol. Usually there's some swelling associated with the surgery too, so you're uncomfortable and the scrotum can be kind of swollen. But usually by 2 weeks, my patients tell me that they're pretty comfortable unless they start, touching the device. Usually around that 2 to 3 week time is when I usually encourage that though, and I have them start inflating and deflating the device, and usually we'll have pain with inflation and deflation. Usually by 6 weeks, most guys can inflate and deflate the device with some discomfort still. 6 weeks is when I give the okay for sexual activity, but it's more at like 3 months where I think that it's completely pain-free and men are very, don't have any pain associated with the implant. The more you pump the device, the more your penis will stretch. I tell patients a lot of times that it's a tissue expander. So if you really aggressively pump your device, you may have some discomfort and pain from fully inflating the device, but what you're doing is you're allowing the device to stretch more. So every time you pump it, you may be able to get a little bit more fullness, a little bit more stretching. I should say, compare it to going to the gym where it hurts when you do your 10th pull-up the first time, but then the next time you can do 12 pull-ups and you get sore. And the next time you can do 20 pull-ups and maybe you feel sore. But the more you stretch those muscles, the more you stretch it out, the more you're able to get in each time. And then hopefully you're more satisfied with your end result. I don't know, Cliff, do you want to give your perspective?
You hit it right on the nose. Exactly right. I was able to, at 6 weeks, have intercourse. I really didn't have pain. I had a little discomfort in pumping it up at the beginning, but the reality was at about the 8th week, I found basically a sweet spot. And when I would pump up, it just wouldn't bother me at all. And after that, you don't even know it's there. So once you're not using it and you're working out and doing things, it's totally innocuous. You don't know. You don't feel.
I often tell my patients that it's like wearing a new big watch, where if you you're not used to a watch, you put a big watch on your wrist and it weighs you down and it feels weird and you look at it. Or maybe this month for me, like you forget that you have a beard for a minute, but then you just get used to it, and it's something that you initially is a change, but then you get used to it and really don't think about it anymore.
It's a great analogy. So if someone wants to get a hold of you, Dr. Goldenberg, what's the best way to do that?
So my understanding is at the conclusion of this webinar, anyone that logged in with their email address should get an email with my information and office information on how to make an appointment. if you want an appointment, it's be happy to see you in the office. I'm the one in our office that really focuses the most on men's health issues. We did bring on a new partner earlier this year that's excellent, who also does a lot of our men's health. His name is Dr. Islam. In addition, we have a physician assistant who will see a lot of our men, especially they say, I came from a webinar, I want to answer more questions about penile implants or about ED options or about incontinence. His name is Mustafa. He does a really nice job. And so if you call our office and say that you're following up about the webinar, we should be able to get you in pretty quickly to see either me or to see one of my partners. And then that's probably the best way. You can also go to our website. It's stlurology.com, and we should have more information about implants and about ED options. And you can also book an appointment through the website.
And again, everybody will receive an email with a link to the website and the phone number to call to make an appointment. But I want to thank everybody for attending. I want to thank Cliff and Dr. Goldenberg. You guys provided so much information this evening. And yeah, we so much appreciate that you take the time to share this with other men. And I hope that people who signed on tonight feel like they've got the information they need to take action in their care. Any final words of wisdom?
Thank you all for tuning in. I think the important part about these talks is really, we present these in a way to really let you know that these are common issues. And I think the first step is really coming out and hearing what the options are, and I'd be happy to help you along your journey.
Well, I would say it's happy holidays, everybody.
Thank you both again. This concludes tonight's Men's Health webinar. Have a great evening.